And yeah, I wanted to tailor the talk to kind of all levels of pre-medical interest, and hopefully you guys find this helpful. Okay, so just to give an overview, we'll go over some background about what's involved in terms of training, certification within radiation oncology in order to become board certified. We'll talk a little bit about me and my path to radiation oncology. And then we'll get into the details of what exactly radiation oncology even is. And we'll talk about some indications for radiation and situations where we use radiation, mainly for cancer, but sometimes for other indications. And then towards the end, we'll talk about a case study from a patient case of mine. So in terms of training for radiation oncology, we are medical doctors. In the United States, you have to go through 4 years of undergraduate training, apply to medical school, go through that whole application process, just as if you're pursuing any other specialty within medicine. So you go through your 4 years of medical school. And then if you decide to pursue radiation oncology, you would have to apply for a residency training position in radiation oncology, which ultimately comes to be about 5 years of residency training in total. It includes 1 year of internship, which can either be in strictly internal medicine, or it can be something called a transitional year, which is kind of a mix of different months spent within different specialties within that year, or it can be a purely surgical internship. And then once you complete that intern year, you go on to your 4 years of radiation oncology residency. So from medical school, when applying to radiation oncology residency, you would actually have to apply for the intern year and the radiation oncology residency separately. You would match to both of them at the same time. And hopefully you get your pick of either or, but they're done within the same application cycle, but they are 2 different spots that you're applying for. So people typically try to pick years that, go in line with their interests. If they're more of a procedural person, they may want to do a surgical internship. And the reason that's even brought up within radiation oncology at all is because we do have a subspecialty of radiation oncology called brachytherapy that is procedural. So some people feel more comfortable doing a surgical internship. So once your radiation oncology residency training is done, you've done your total of 5 years. Some people opt to go on to do a fellowship, though this is definitely not required because you're already so specialized as it is. Typically, if you're going to pursue a fellowship after the residency in radiation oncology, it's because you're interested in something very specific, such as brachytherapy, which is procedural, or you're interested in giving a specific type of radiation treatment, such as proton therapy, which is a specific type of particle radiation that we deliver for different reasons. So these fellowships typically are 1 year long, and they're kind of scattered throughout the country at the larger academic institutions. Okay, so moving on to exams and certification within radiation oncology. As you've probably heard from the other speakers, you have to go through the USMLE certification steps and qualifying exams. So we have to take step 1, 2, and 3, pass all of those successfully. And you have to then take on your board certification, which is done through the American Board of Radiology. Radiation oncology many years ago was considered a part of radiology. However, we are now our own specialty. And so the board certifications are completely separate, but the American Board of Radiology still kind of dictates our examinations and certification. So in order to become a radiation oncologist, you have to pass what are typically 3 sets of board exams. So the first 2 are the radiation biology and the radiation physics exam, which are typically taken together. This past year has been a little bit different for residents because of the pandemic, and there is an option to take these two exams separately. They are each their own exam, but the most common situation was to just take them both in the same day. And then once you're done with those exams and you've successfully passed those, you would go on to take the clinical written radiation oncology exam, which tests your clinical knowledge of radiation oncology, how to treat cancer patients with radiation, when it's indicated, things like staging, recurrence rates, survival rates, et cetera. And once you've passed that, you move on to your oral board examination, which is essentially done with a panel of experts who will give you patient cases, ask you to work up the patient, ask you how you would treat the patient, and kind of go through a series of questions based off of your responses. And so after the oral board examination, then you're finally done with your board certification for radiation oncology. So a little bit about me. As I said before, I'm a practicing radiation oncologist. I'm also a brachytherapist, so I do procedural radiation, which is different from external beam radiation. So external beam radiation is delivered via a machine, which is typically a linear accelerator. Brachytherapy, however, utilizes radioactive sources that are either placed directly into a tumor or directly into a body cavity. And then a radioactive source is either passed through applicators or the source is directly implanted, and it delivers radiation kind of from the inside out. So that radioactive source is giving out radiation from itself that started in medical school at Jefferson Medical College in Philadelphia, or Sidney Kimmel Medical College as it's called now. And I found radiation oncology towards the end of my third year. It actually just happened by chance. I rotated on the specialty and thought that it was really interesting because you get to work with cancer patients, but not only do you get to prescribe a treatment that will help them, you get to directly and precisely guide where the treatment is going, and you're very involved in that process. And I kind of found that just pretty interesting. The technology is always changing as well, and I like that aspect of the field. And it's generally like research-driven, evidence-based medicine field, meaning that we rely heavily on data from randomized trials or the next best level of data out there to help dictate what types of treatments we'll prescribe. So once I kind of found radiation oncology and I decided to pursue it, I got involved in research projects within the Jefferson Radiation Oncology Department, did some networking, and was able to match into radiation oncology. I did a transitional year for my intern year at St. Luke's, which is in Pennsylvania. And then I moved on to my residency training at Montefiore Albert Einstein College of Medicine in New York. I actually stayed on as a faculty member after I graduated from residency last June. So I'm approaching my 1-year mark of being in attending for 1 year. My clinical focus is in mainly GYN cancers, breast cancers, central nervous system, tumors, and palliation. My research focuses mainly on locally advanced cervical cancer and brachytherapy, as well as other GYN cancers like uterine cancers. I also do research within the realm of COVID-19, as well as disparities in cancer care, equity in healthcare and workforce diversity, and radiation toxicity. Some interests of mine that kind of fall outside of that research role include radiation oncology awareness and kind of educating people about our field, about radiation in general, because there is a lot of fear surrounding radiation, and I think it's helpful to talk about it and, give ourselves a platform. I also am interested in social media use for the academic setting and mentorship. So what exactly is radiation oncology? Radiation oncology is a field of medicine that's mainly focused on the use of therapeutic electromagnetic radiation. So we mainly use this for cancer treatment, but there are some benign entities which we will treat with radiation that you may not realize. An example of this is something called refractory keloids. Keloids are a type of abnormal scarring that happens in certain patients where their scar mechanism is kind of overactive, and then they get a mass, which is generated from an overactive healing process. So those are typically treated surgically or with steroid injections, and at times they can be painful, itchy, and even disfiguring. If they don't respond to the other treatments, then oftentimes we can use radiation after surgery to reduce the chance of the keloid growing back, and it seems to be quite effective. Okay, so just to put in context, in terms of how cancer is affecting people within the United States, we have here the cancer statistics from 2020. So this is some data that's put out very frequently that assesses the incidence as well as the death rate from cancers in people in the United States. So we can see here that for both sexes, lung cancer is quite common, as is colon cancer. These top three here are kind of, the most common cancers, and the top spot varies based on the gender, right? So males are more affected by prostate cancer because they have a prostate, whereas females do not, and breast cancer is the most common for females. In terms of death, lung is the main driver of death from cancer in this country, and then prostate comes in second for males, breast in second for females, and then colon in third for both. And you can kind of see the breakdown of some other common cancers below that as well. So what sorts of cancers do we treat with radiation? We treat a myriad of cancers with radiation that oftentimes is a surprise to some people. So we can actually use radiation to treat prostate cancers. We can use it in the treatment of breast cancers when we're doing breast conserving therapy, meaning that they're going to keep their breast, and we're going to remove a small portion of the breast where the cancer is and give radiation to the breast afterwards. We can also treat lung cancers with radiation, some that are very early stage, like stage 1 inoperable, and they can't have surgery. We can treat those with a targeted form of radiation called SBRT. Head and neck cancers, GI cancers, GYN, and the list goes on. So we're involved in many common cancers. However, the way in which we're involved and what the intent of the radiation is kind of what is different amongst the diagnoses. So the intent is important here. We want to kind of make clear what we're aiming to do with the radiation. What is the goal? So we can have the goal of curing the cancer, meaning that we want to get rid of all cancer cells and the patient will have no active cancer left after treatment. Or we're treating in the adjuvant setting, which means we're treating after a prior treatment. So typically that's after a surgery, and there are some risk factors that came back on the pathology report after they looked at the specimen under the microscope and said, there's certain risk factors here that make this more likely to come back. Let's give radiation to help decrease that risk. Or we can be treating in the palliative setting. In the palliative setting, we're typically dealing with patients who have metastatic cancer, meaning the cancer has spread through distant parts of the body outside of where the cancer started. So those patients, we're no longer trying to cure or get rid of their cancer. It's presumed that their cancer is not curable. However, depending on where tumors or metastases are situated, they can cause symptoms, sometimes pain, sometimes dysfunction of an organ, depending on where they are, that are very uncomfortable for the patients. And sometimes we're able to control that to a certain extent with pain medications. However, radiation is often used to control pain, and it's a great way to shrink tumors and to reduce symptoms from metastatic tumors. So examples of things we treat with quote unquote palliative intent with radiation include bone metastases that came from other sites such as the lung or the breast and spread to the bone and are causing pain. We can treat those with radiation. Sometimes patients get brain metastases. The best example is you have a patient with lung cancer that gets brain metastases from the lung cancer. If they're small and they're localized, we can treat them with a targeted form of radiation called stereotactic radiosurgery, where we're just targeting that individual tumor region and not the entire brain. Or if the brain mets are more diffuse and spread out throughout the brain, then oftentimes we do have to use whole brain radiation. Going back to curative intent radiation, some examples of things that we can cure. A great example is inoperable lung cancer. So a patient comes in with an early stage lung cancer that, they're deemed a high surgical risk and they can't have surgery. We can actually do a targeted form of radiation called stereotactic body radiotherapy and, have the intent of curing those patients. Anal cancers and skin cancers can be treated for cure, and some locally advanced head and neck, as well as cervical cancers and prostate cancers are treated for cure with radiation. In the adjuvant setting, meaning after surgery or after a prior treatment, the most common example is in breast cancer. After a surgery is performed, typically a lumpectomy where they remove a small part of the breast with the tumor, we give radiation to the breast to decrease the risk of a local recurrence. In the adjuvant setting, we also use radiation for uterine cancers after surgery and for some lymphomas. So how does radiation actually work? What's actually happening in the body? Radiation, that we're using for treatment purposes is in this end of the electromagnetic spectrum. So we're dealing with X-rays and gamma rays of high energy that are intended to cause a change to the tissue or the medium it's going through. So ionizing radiation actually deposits energy as it passes through a tissue and then causes changes to that tissue. So what do I mean? In terms of the biologic effect of radiation, the radiation as it's passing through tissues of the human body, they're interacting, with cells. Cells make up tissues, tissues make up organs, organs make up your body system. Everything that's happening with radiation is really happening on a much smaller level. So the radiation is passing through cells and it's actually causing DNA damage within the nucleus of the cell. So in the center of the cell here where the DNA is housed, the radiation will cause damage. And it's either by directly damaging the DNA, as you see here, or it finds a water molecule and uses that to essentially cause more damage. And I want to get into the details of this because I think it's kind of a bit of a level above this talk, but in the grand scheme of things, it's causing a damage to the DNA, which then makes it almost deadly for the cell to divide and grow. So in terms of cell biology, cells quote unquote divide to grow. And that's how tissues are maintained and replenished. And so when you have radiation hitting the DNA, it causes an issue in the genetic print that the cell uses to basically make a copy of itself. So when cells try to divide and make another one of itself, it runs into problems because of the damage to the DNA that the radiation caused. And typically what happens is the cell dies. When that happens is a much higher level of detail, but to simplify things, the DNA damage is causing a problem where the cell can no longer divide, and if a cell can no longer divide, it dies. This process will happen within, cancer cells. Cancer cells are typically rapidly dividing cells. They want to divide frequently and make more of themselves. That's part of the reason it is a cancer. And so because they constantly want to divide, when they're hit with radiation, they're very susceptible to dying off because of the damage from the radiation, because they're typically trying to keep going and dividing through the cell cycle. The same thing can happen in normal cells of normal tissues within the body. Each cell has a different level of sensitivity to radiation based off of many factors, but especially the cell cycle and how frequently it's dividing. So we're talking about all this DNA damage and causing cells to die. So is it dangerous to be a radiation oncologist? This is a common question. And the answer is no. We actually have all of our machines housed in radiation vaults that are extensively shielded to protect against radiation leakage. We also wear radiation badges that are used to measure radiation dose that we're exposed to. And if the level is anywhere above where it's supposed to be, you actually get alerted immediately by an institutional designated official. And sometimes an investigation is conducted to make sure we know why the levels are off. And that doesn't happen often. When patients are treated with radiation and the beam turns on, nobody is in the room with that patient. It is the patient by themselves. There's no physicians, no therapists, no nursing in the room, just the patient. So it is safe for females of childbearing age to pursue radiation oncology. We even have staff that are pregnant that work within the department, and they have their own set of rules and regulations for just keeping track of exposures. But it is definitely safe for women and men seeking childbearing capacity. So who makes up the radiation oncology team? So we have the physician or the radiation oncologist. We also have nurse practitioners and physician assistants that can work with us. Typically, these are mid-level practitioners that can see patients and prescribe medications, but the radiation treatment is always prescribed by the radiation oncologist, and any planning is done by the radiation oncologist. We also have team members that help us basically make a radiation plan and then make it deliverable. A medical physicist is a very important part of our team. Their job is to basically make sure that we can deliver our radiation plans both accurately and safely on the machine. We also work with a team member called a dosimetrist who is responsible for making the radiation plans from essentially something called contours, which I'll explain in a few slides. But contours are essentially drawings that the physician makes and says, what dose of radiation, where the radiation should go and where the radiation should not go. And the dosimetrist creates a plan using computer software to achieve those goals. The radiation therapist is somebody who is a therapist that's job is to work with patients on the machine. So they set the patient up on the machine, make sure they're lined up to the correct area using lasers in the room. And then they actually take any imaging that's needed on the machine before treatment and deliver the treatments. So the physician is not sitting at the machine delivering the treatment, the radiation therapist is. We also have nursing and radiation oncology, which are hugely important. These patients oftentimes are not only getting radiation, they may also be getting chemotherapy, so they can be quite sick. They require, sometimes blood work, sometimes fluids to help them kind of get through their treatments. The patients are seen on a weekly basis typically to make sure that they're doing okay with treatment. And so the nursing staff is really, extremely helpful with patient care. We also have social workers within radiation oncology and nutritionists, which also help us deal with barriers and access to care, as well as nutrition of our cancer patients as they deal with cachexia and difficulties maintaining their weight. Okay, so some qualities of radiation oncologists that I think are important to point out. You need to have a good understanding of cancer biology and the cell cycle, as well as nuclear physics, anatomy, and cancer staging. We also have a good understanding of the radiation toxicity or side effects that are caused by the radiation, and how it affects normal tissues and how we can deal with those side effects. And as I mentioned previously, we have a great understanding of research and evidence-based medicine using data from the literature, from randomized trials, to help guide our decisions and how to treat patients. I also wanted to point out that radiation oncologists tend to be forward-thinking. Research and I think forward-thinking kind of go together. The technology that we use is kind of changing always and always improving so that we can reduce any side effects or toxicity from the radiation. And radiation oncologists are always thinking of how we can treat patients with less toxicity and improve the quality of the treatment we're giving. And then outside of the knowledge that you need to have to be a radiation oncologist, it's very important that radiation oncologists have empathy, compassion, and a concern for patient rapport, because you have to remember we're dealing with cancer patients who are often dealing with, either devastating diagnoses or, very difficult diagnoses that have them, very, very concerned and needing of support. Sometimes, this may be the most difficult thing they deal with in their life. And you need to be able to, communicate the facts to the patient while also delivering it in a way that, keeps in mind their emotional well-being, and how to work as a team to get them through treatment. So, sorry, I was just looking at the chat here. The radiation oncology workflow is something that is essential to understand how we go about treating patients. So, we start off with a consultation where we meet the patient. We take a history and physical. We do an examination. We take blood work, and we review any available imaging, diagnostic studies like pathology, and kind of use all of those pieces of information to decide, number one, what stage the patient is, and then after we determine a stage for the patient, what is the appropriate treatment option for that patient based on the stage. We oftentimes discuss each patient case at something called a tumor board conference, where we essentially have colleagues from many different disciplines within medicine that come together to discuss a patient case. And I'll touch on that in just a minute on another slide. So after we decide that a patient needs radiation treatment, the next step is to move on to something called the CT simulation, which is essentially like a dry run of the radiation treatment. We set the patient up in the treatment position and take measurements, as well as make molds of the body area that we're going to treat so that the patient's immobilized and not moving during radiation treatment. And then a CAT scan is generated in that position. And those CAT scan images get sent to the radiation oncologist. And we move on to this step called contouring. Contouring is essentially just drawing of tumors and areas at risk for tumor spread, as well as normal organs in the area that we want to spare from radiation. And so we kind of draw those areas out, and then we say we want this dose of radiation to go here and not here. And those contours on the CAT scans are then given to the dosimetrists and the medical physicist team, who generate a radiation treatment plan using computer software they generate a plan. The plan is then communicated and sent back to the radiation oncologist. We review the plan and we review all the dosing, not only to the target areas, but to the areas of normal organs to make sure it's safe to deliver the radiation. And then if everything looks okay, then the patient is approved for treatment and they come, for treatment day on the machine. Okay, so we'll touch a little bit more in depth on each of these stages of the radiation workflow, and I just wanted to kind of break down the anatomy of staging for you guys. So typically, the most common staging system that we use is the AJCC 8th edition of staging, and that uses something called the TNM staging. So the T category typically describes the primary tumor, and it describes things such as stage, how invasive it is in the area, and how it relates to the anatomy. The N category describes whether or not the cancer has reached nearby lymph nodes. And then the M category kind of tells you whether the cancer has spread to other distant parts of the body. And once you have the whole TNM category done, that basically gets calculated into a final stage. So just to give an idea, an example of this TNM staging, this is from this 8th edition staging manual. So here we have a T1 breast cancer, here we have a T2 breast cancer, T3, and so on. So you can see as you move through these T stages, the cancer is actually getting bigger in size. And in some cases, it's getting more invasive in terms of the areas of the anatomy that the tumor is involving. So, just to make this more clear, we have a T1, which is very early stage. Here, a small tumor. And then if you look at the difference between a T4, this is invading the chest wall here. It's quite large versus this T1. So obviously this cancer is a lot more advanced, and that translates into an advanced stage and is used for treatment and prognosis. So moving on to the Multidisciplinary Tumor Board Conference, this is basically a meeting that happens at most large academic institutions and cancer centers, usually weekly for each disease site, for each type of cancer, where we have different members of different teams come together. So who is in the tumor board conference? Typically, you'll have a surgical oncologist or a surgeon that has the responsibility for removing cancer. So it can be a urologist if we're talking about prostate cancer. It can be an ear, nose, and throat surgeon if we're talking about a head and neck cancer, or a GYN oncologist if we're talking about a gynecologic cancer like uterine cancer or cervical cancer. And then the radiation oncologists are typically there. We are the doctors that would treat with radiation. Medical oncologists are present. These are the doctors who would use chemotherapy or other targeted systemic treatments that can go throughout the whole body. We also have radiologists who review the imaging and kind of give their expert weigh-in on the imaging that the patients had. And pathologists. And the pathologist's job is to look at the biopsy or the specimen of the tumor under the microscope and give us the correct diagnosis of what type of cancer it is, as well as any tumor characteristics that give us a clue about prognosis or the way the cancer is going to behave. So all of these specialists come together to basically weigh in on their respective areas in a patient's case. And, we can have discussion back and forth about what we think is appropriate for a patient. And, we're coming from different perspectives in medicine. So ultimately, it's important because you end up having a more well-rounded discussion for the best plan of treatment for each individual patient. Each physician actually learns more about other specialties because you're all forced to be in a room learning about things from one another. And at these meetings, we oftentimes have nursing staff, medical students, and other staff. So it's really educational for everyone. So the CT simulation, as I mentioned before, we decided the patient needs radiation. We're going to need to get a CAT scan generated, and in order to plan the radiation. So the patient is simulated or basically set up in the treatment position, and measurements are taken in order to help guide the placement of the radiation beams in the planning process. They also have a mold of their body made depending on where in the body we're treating. If they're going to have something in the brain or the head and neck region treated, then they will actually get a mask made of their head and neck that goes over their face and neck and gets attached to the table. For tumors that are in areas that have a lot of motion, for example, due to breathing, like in the lung or the GI system, the diaphragm is moving in a way that, the lungs expand, and that can actually cause the tumor to move either up and down, side to side, or front to back. And we need to know about this motion in order to do, targeted treatments. So oftentimes, like in a lung cancer, we'll get what's called a 4D CAT scan, where we're actually tracking in time the movement of the lung tumor. So contouring, once we actually, perform the CT simulation, they're in the treatment position, they have the CAT scan done in the treatment position, we get those images, and we go through each area that's within a close distance of the tumor, and essentially draw out the areas that we want radiation to go to, and also draw out normal areas or normal organs that we don't want the radiation to go to. So here in the bottom, we have a CAT scan here of a patient with locally advanced lung cancer. This is his tumor here in red. He has a stent in place because he had difficulty breathing and was admitted to the hospital with some bleeding complications, and had to have that placed emergently. So this is his tumor here. Here we have just below what's called the carina, or where the main bronchi kind of emerge from the main trachea. And then just in front, we have the heart, and just in back, we have the esophagus. Normal tissues, these normal organs, are all areas that we want to try and spare from the radiation. It's easier to spare some versus others, such as, the left lung here is going to be much easier to spare per se than, say, the esophagus, which is really abutting this tumor here. But, we try our best, and we actually have limits of radiations for each organ called dose constraints that we take into account heavily in the planning process when we look at where the radiation is falling. So that's a lung cancer patient. On the right-hand side here, we have a head and neck cancer patient. And this patient is an example from one of the contouring publications. This patient has 2 lymph nodes here that they're trying to target in this radiation field. And then they also have this area out here, which is basically what we call a subclinical space, or an area that's at risk for microscopic tumor that we can't see with imaging or, with any form of medical diagnostics, because they're on the cellular level. But we know that they're at risk just based off of surgical data. And so we cover those areas with radiation. So up here, we have an example of the different nodal levels within the neck. Each one of these areas is at risk for tumor spread depending on where the primary tumor is situated. And so you can see here that, we don't treat all of these in every case. You have to basically pick out the levels that are at risk based on the case. So you do need to have a deep understanding of anatomy in order to be able to draw these spaces out on CAT scan or MR imaging. Okay, so once the contouring is done, those drawings get sent to the dosimetrist, who use the computer software to generate a radiation plan that essentially uses an algorithm to prioritize the targets to receive the radiation and the organs at risk to not receive radiation, or at least amount of radiation as possible. So on the right side here, you can see an example of a head and neck patient who this case was actually a supraglottic larynx cancer. So it was a type of throat cancer who had lymph node spread. So on each side, he has a lymph node here, lymph nodes here that need to be targeted in the radiation field, as well as the nodal levels where those lymph nodes reside. So the colors here that you're seeing is something called a dose cloud or a dose color wash, where the red, orange areas are a higher dose, and then the green and the blue areas are a lower dose of radiation. So you can see here that there's this area, this gap of radiation here, where the planners are trying to spare the spinal cord. And then if we look up top here, this yellow contour here is the bottom of the oral cavity. This is the mandible, or the chin here, the bone of the chin. And you can see the radiation is trying to be carved out of that region as well to spare those areas of radiation dose as well, while still trying to cover the nodal areas at risk. Up here is an actual projection of the beam arrangement. So in radiation, you have a big machine that's essentially aiming beams of radiation. And so in order to create a plan that looks like this, you need many beams from many different angles to be utilized in a strategic way so that you can try to spare some of the normal areas while aiming at the targets. Okay, so treatment. Once that plan is sent through, dosimetry, they give me a plan. I say the plan is okay. That plan is then sent to the hands of the medical physicists. The medical physicists are going to make sure that that treatment plan is going to be delivered accurately on the machine, as well as safely. So once that process has been completed, it's time for the patient to come for the actual treatment. They can get treatment on a linear accelerator, which is the most common type of treatment we do, but we also have radiation treatment machines that are helical. So this picture here is a linear accelerator, and it looks like a long arm, and the patient lies flat on the table in their immobilization device, and the machine rotates around the patient, delivering the radiation beams from different angles. We have helical radiation machines that kind of look like the CT donut shape, where instead of an arm here, it would just be a circle, and the delivery device would be rotating in a circle around the patient. Gamma knife and cyber knife are types of radiation treatments that are used for stereotactic radiation, or radiation treatments that are very targeted into small regions and precise. And so when the patient is ready for treatment, typically they have imaging acquired actually done on the machine. The machine itself has an imaging capacity. So it'll take like an X-ray or a CAT scan that basically is then lined up to the planning CAT scan and used to determine whether or not the patient is in the correct position for treatment. So when a patient is starting, or we're giving very high doses of radiation in a few treatments, the physician has to be present at the machine to review those imaging scans and confirm that we're treating the correct area and the patient is in the correct position, and we can deliver the plan safely. Okay, so different types of treatment modalities within radiation I wanted to touch on. Radiation oncology, radiation itself has gone through many changes over the years, and I think this is something that's kind of lost depending on when you trained in medicine. So we're giving much more accurate and technologically advanced treatments nowadays than we were, 15, 20 years ago. And so I just wanted to touch on the different treatment modalities that we have. And this is not an extensive list, but enough for the purposes of this talk. So radiation, previously was very limited in terms of how we delivered the radiation. So the more limited modalities, how I refer to them, would be 2D or 3D radiation. So that means we're giving radiation only using beams in 2 dimensions, so like front and back or side to side, or 3 dimensions. But radiation has progressed, and we now have different types of more advanced treatments. So IMRT stands for intensity modulated radiation therapy, which is where we use many different treatment beams coming from different angles to try and get the targets to a higher dose of radiation while sparing the normal organs. And that picture I showed you previously here, this is an example of IMRT. We're using many different beam angles to try and get the best plan possible for that patient. We also have something called stereotactic radiosurgery, which down here you can see this is an example from the Gunderson textbook. This is a patient with brain metastases, and they have one small brain met here that's being targeted with the stereotactic radiosurgery. This can be done with either a linear accelerator or a gamma knife, which is a special type of equipment that's specifically for stereotactic radiosurgery. And as you can see here, we're only targeting the tumor itself. And at times we'll put a very tiny, like millimeter margin around it. But we're really trying to spare the rest of this normal brain tissue and only have the radiation intensified in the tumor here. Stereotactic body radiotherapy is a very similar concept to stereotactic radiosurgery. It's just that for SBRT, we're delivering that in an area outside of the brain. But the concepts are the same in terms of treating a small area with a small margin and trying to spare much more of the normal tissue. We'll skip here to proton therapy. Proton therapy utilizes proton beams, which are different from other types of external beam, which utilizes photons. And again, this is a little bit above the level of this talk, but essentially with proton beam therapy, we're able to use the physics concept of the proton beam, where it can be told to essentially stop at a certain distance. So if you look up here, this is an example of the difference between proton beam planning, where you have essentially no radiation dose exiting out here in front of the patient, versus these plans where you have much radiation dose exiting out. And so you're sparing a lot more of the normal tissue than you would otherwise. So we use proton beam therapy often in pediatric or kids because they can have long-term effects from the radiation itself if they need it at a young age. And so we always try to spare them as much radiation as possible. And then finally, brachytherapy is the procedural radiation that I was talking about before. And I have a specific slide on this because I'm a brachytherapist, so I have to give a little bit more detail. Brachytherapy is basically the use of applicators like the one you see down here. This is a type of tandem and ovoids applicator for cervical cancer. So this long stick-like figure here is called the tandem. That piece actually goes transvaginally through the cervix into the uterus. And it's the piece here that you see projecting on this CAT scan and here into the uterus. This is the bladder, this is the rectum, and this is the sacrum. So this is like your buttock region, the back of the patient, this is the front of the patient, and this is the vaginal canal. And so these side pieces here are called the ovoids, which get introduced through the vaginal canal as well. And they sit kind of up against the end of the vaginal canal, just underneath the cervix. So that's a type of brachytherapy that we use in cervix cancer, which is very important for locally advanced cervix cancer for survival, because it actually boosts the tumor in the cervix itself to a higher dose that makes cure possible. And that is not achievable with external beam radiation. So when you put these applicators in directly into a tumor, you're sitting in the tumor or right next to the tumor. And so a radioactive source will then be traversed through these applicators by a machine that does this automatically. So no one is in the room touching radioactive sources. But the radioactive sources travels to this point and it delivers radiation from the inside out. And so the cervical tumor in this case gets a high dose of radiation, but the dose from the source falls off or decreases rapidly with distance. So I can get this cervical tumor to a higher dose than I could if I had to try and do this with an external beam plan where beams are coming from the outside and having to pass through normal tissue versus from the inside out. So I like this quote from one of the textbook that says brachytherapy is arguably the most conformal of all modes of radiotherapy, meaning that you're able to get that high dose in the tumor and shape it and sculpt it so that the dose to the normal organs, like in this case, bladder, rectum, small bowel, are much less than they would have been from an external beam plan. So you get a lot better normal tissue sparing with higher doses at the center. So that's an example of GYN cancer. We also use brachytherapy in prostate cancer, which you can see an example down here. In prostate cancer, this is what's called prostate seed brachytherapy, if you've ever heard of that, where we actually implant radioactive like seeds or pellets directly into the prostate in the operating room. And those seeds sit in the prostate permanently, delivering radiation based off of what's called a half-life of the radioactive source. Other times we use brachytherapy. We can use it certain times for sarcoma, keloids, and sometimes head and neck reirradiation, just to give a few examples. So just cases where we want to give a high dose close to an area, but spare toxicity elsewhere. I like brachytherapy a lot because I think it makes you, be a lot more creative. It's procedural, so you get to use your hands. It breaks up the day nicely. And of course, we get to wear scrubs, which is always fun. Okay, so just gonna move on to the case here. Hopefully we're doing okay on time. Okay, so this is a patient of mine, so we'll quickly go through this case and then I'll open it up to questions for everybody. So this is a 67-year-old female who had a past medical history of hypertension and uterine fibroids, who presented with right-sided pelvic cramping for 8 months. She went to see an OB/GYN or a gynecologist, and on examination with a speculum through the vagina, visualizing the cervix, she was noted to have a cervical polypoid lesion. She ultimately had a procedure called a cold knife conization performed, where they essentially take a piece and cut out a portion of the cervix with the tumor. And that was reviewed under the microscope by pathology and showed a cervical squamous cell carcinoma or cervical cancer. So she was then referred to GYN oncology. Gynecologic oncologists are actually a super specialized type of gynecologist. So they actually have their own separate training outside of gynecology. And they are experts in GYN cancers, and they are surgeons. So a GYN oncologist is typically involved always in a cervical cancer workup. So she was seen by my GYN oncology colleagues as well as myself in radiation oncology. When I saw her in the office on speculum and bimanual pelvic exam, which is a transvaginal exam where we actually try to feel around the cervix, which is a ball-like structure at the end of the uterus. We noted that there was an approximately 4 centimeter bulky cervical mass that may have been extending into what's called the right parametrium. No sidewall involvement or fixation and no vaginal involvement. This is to say that the extent of the tumor was enough that this was likely not a good surgical case. If it's involving the parametrium, which is an area kind of next to the cervix and uterus that helps suspend these structures in the pelvis, then the chances of getting a good surgical resection without positive margins are less, and she may need radiation after the fact and potentially chemotherapy anyway. So we try not to do 3 modes of treatment and spare toxicity, and instead for locally advanced cervical cancers, elect a definitive chemoradiation treatment. So a combination of external beam radiation with chemotherapy for cure. So just to touch base on the workup for a cervical cancer, you typically do a history and physical. You want to get a complete blood count, which looks at different types of cells within the blood. Oftentimes these patients are anemic because their cervical cancers can bleed heavily, causing them to lose blood and become anemic or have their blood count drop. You obviously want to get a cervical biopsy so that you can confirm that there is cancer there and it's not something else that's benign or a step below cancer. And you want to assess their liver function as well as their renal function. Oftentimes, if a patient has a very large locally advanced cervical cancer, it can actually grow out into what's called the pelvic sidewall and cause an obstruction of their draining genitourinary system, so that urine actually backs up to their kidney and they may start getting kidney damage and require a stenting procedure. So this can be important in locally advanced cervical cancer. You, of course, want to get imaging for staging purposes. And in patients that have large locally advanced tumors, we oftentimes take them for what's called an exam under anesthesia, which means they're asleep instead of being awake in the office. And so we can actually get a better examination of the vaginal structures, the cervix, and how far out the tumor is extending. We also oftentimes take a look inside the bladder and inside the rectum using cystoscopy. Cystoscopy is for the bladder, proctoscopy is for the rectum, to rule out any invasion of those structures, because if a cancer is left to grow long enough, it can invade the bladder and the rectum. So this patient had a PET CT performed as part of their staging workup. And as we can see here on the right side, she had what's called an FDG avid mass. So in PET scans, you use this radioactive and in this case looks red to us when we review the imaging, and signifies that there's cancer there. On PET scans, you can oftentimes have other structures that light up bright or red in this case that are not cancer, and that has to do with the dye being taken up in an area. So an example of that here is this area here is actually her bladder. Her uterus is sitting here on top, and I know this is very difficult for people to make out because of the PET scan, but just to give you an idea. So the red arrow is pointing to her cervical cancer, and this area is her bladder, and her uterus is sitting up here. So on this scan, they found that she had this very avid cervical tumor measuring 4 centimeters, and they also picked up on a suspicious pelvic lymph node that looked like it lit up bright as well and was suspicious for cancer. So this same patient went on to have an MRI of the pelvis done, which we oftentimes do because MRI provides a much better picture of the pelvic organs and the extent of the cervical tumors. As you can see, from this to this is like night and day. So MRI is very helpful in this clinical situation. So on this MRI, we have the patient's uterus here. She has what are called uterine fibroids, and that's what these dark structures are here within the uterus. And then back here, which is essentially the bottom of the uterus or the cervix, you can see this dark structure here, which is actually her cervical cancer. And it looks like it's extending outwards here. Back here, we have the rectum. These are the pelvic bones here. And we have some small bowel here. So on the MRI, the radiologist noted that she had a 4.3 centimeter cervical neoplasm with gross extension of the mass into the right parametrium. So we picked up on a little bit more detail in terms of how extensive the tumor was on the MRI that did corroborate with our physical exam, which is always nice. And that actually affects the patient's staging. So for cervical tumors, we stage them according to a system called the FIGO staging, which was recently updated in 2018. So this table here kind of provides a nice summary of the staging and what goes into it and what we pay attention to give the patient their stage. So to cut to the chase for this patient, because she had parametrial involvement, she automatically falls into this 2B category. But she also had a lymph node, a positive pelvic lymph node positive. So then she was upstaged to a 3C1R. The R means that it was found on imaging or radiology, which was new in the 2018 staging. So ultimately, this patient has a locally advanced cervical cancer. It is not operable. It's not recommended that she have surgery. And so instead, we treated her with definitive chemoradiation. And that involves external beam radiation targeting the uterus, the cervix, the vagina, and pelvic lymph nodes, which goes on for about 5 weeks, followed by a lymph node boost and a brachytherapy boost to the cervical tumor. She will also get concurrent or at the same time chemotherapy with weekly cisplatin, which is a type of platinum chemotherapy. So these are some frames from her actual treatment plan. She was treated, with an IMRT plan. You can see that we have many different beams coming from many different angles here, trying to achieve that purpose of getting radiation to the target while sparing the normal organs in the area. This is an example of her contours from a sagittal image, or if you cut the body down the middle, like sideways, that's how a sagittal projection is thought about. And so here we're looking from the side of the body, and you can see here that her cervical tumor is located here. Her uterus is quite large and it's extending out here. Okay, and then you have her bladder in front and her rectum in the back here. And this is her sacrum and coccyx again. So this is the back and this is the front, and you have small bowel sitting up here on top of her uterus. So her treatment plan, targets essentially all of her pelvic reproductive organs, as well as draining lymph nodes in the pelvis that are at risk for microscopic tumor spread or tumor spread that we can't see on imaging. And so that's why in this dose cloud or this, radiation dose wash, you see all of this area getting radiation. And it's hotter at the center here because her cervical tumor and any gross disease that we can see with imaging gets boosted to a higher dose of radiation. So after she completes the 5 weeks of external beam radiation and her lymph node boost, which typically goes on for another week to week and a half, she then moves to brachytherapy, which is the procedural radiation. In locally advanced cervical cancer, this is an absolute must in order to boost the cervical tumor to a curative dose. So in order to perform brachytherapy accurately, you need to select the right applicator that's going to be able to cover the tumor, and that's mainly based on size and extent of the tumor. So in her case, we chose this tandem and ovoids applicator here with the option to place what are called interstitial needles. So on the ovoids down here, it's a little bit hard to see, but there's some openings here where you can actually place a needle through. And so if you see here, this is loaded with a needle and something called a guide tube, which guides the needle. It's placed into the patient, and once I get a CAT scan and I like the placement of the tandem and the ovoids, I then decide if I can place a needle, and I then push this needle in by a few centimeters. And so that's an example of the needle here on what's called a coronal projection. So applicator placement, can be uncomfortable for the patient. It can be, can cause bleeding. It can be dangerous because you're trying to avoid normal organs like the bladder, rectum, and the small bowel. And so this requires, advanced imaging and an attention to detail so that these applicators are placed correctly with few complications. So this patient finished her brachytherapy and she finished all of her treatment regimen. So she came in for her 3-month follow-up and she was doing well. She said that she was having some transient diarrhea, which has since resolved. She's also having some burning with urination, which has since resolved. And she feels like her appetite's improving and she's getting some energy back. And she's essentially ready now to do what's called the three-month post-treatment PET CT. So this is when we typically get a PET scan after treatment of a locally advanced cervical cancer to see how they responded to treatment. And, is the cancer subsiding or is it getting worse? And how do we proceed next? So I just wanted to quickly touch on radiation complications because, I mentioned that she had some diarrhea and some burning with urination, and that has to do with where, we're targeting because the bladder is sitting right in front and the rectum is sitting right in back. And in some cases, the small bowel can actually come down close to the treatment area. And that causes the symptoms that she was having. Radiation to the bladder can cause burning with urination, and radiation to the rectum or the small bowel can cause diarrhea. They typically happen during treatment and typically resolve after the treatment if they're going to happen. However, some patients do have long-term complications based on how big their tumor was, how much dose the rectum or the small bowel or the bladder received, and that all varies. So radiation treatment complications can be acute or happen during treatment or within the few months after treatment, or they can be long-term, many months after treatment to years after treatment. It depends on the disease site and what part of the body you're treating and what normal organs are close by. It also depends on the dose of the radiation given and for how long and how often the radiation was given. And this were used to try and minimize the risk also plays into this and whether we were able to meet those constraints. And each patient, is individual, and these side effects can vary from patient to patient. So in this patient, she had her 3-month PET CT, and here we have her 3-month post-treatment PET. And here we have her original PET CT. And so here we're at the level of the femoral heads. So down in the pelvis, this is the front, this is the back, this is the rectum here, and this is the front of the patient. You see again her uterus here, and it's actually a nice picture of her fibroids, which often have calcifications in them, which show up bright white on CAT scan. So that's what those are. And then behind that, we have the cervix and the vaginal fornices, or the top of the vagina. And so we can see in this region, which was where her tumor was extensive outwards into the parametrial area, and the initial scan here, we can see that the uptake, or this red area, is almost gone essentially on this post-treatment PET. So this is a substantial improvement and excellent result. meaning that her cancer responded to the treatment, and she's actually doing quite well. So the radiologist stated that there was a slight decrease in the size as well as the activity of the previously seen cervical mass. And now they're just seeing what's called heterogeneous activity throughout the cervix that they think is related to post-radiation changes, meaning not related to active cancer. They do notice some areas of her uterus that look a little bit abnormal, as well as noting that there are no more lymph nodes in the pelvis that light up bright. So this is all great news for this patient. It means that her cervix cancer is controlled and she needs to remain in close follow-up, but she has an excellent response to treatment, which actually gives her a better prognosis in terms of how her disease will be going forward. So that's the end of the case, and I just quickly wanted to touch on some tips for navigating through, the pre-med process or medical school, just because it is a journey, and I think it's helpful to hear, different perspectives. So I think it's important to build up your experiences in medicine. Try to seek out shadowing opportunities, which can be in person or virtual, such as this event. I think, there's never too many things that you can do because each experience you may have may be different. If you get the opportunity now that things are opening up a little bit and you're vaccinated, maybe doing an in-person shadowing experience in an office where you get to see actual patient interactions is definitely helpful because, one of the best parts of medicine is interacting with the patients and, having that connection with patients. So I definitely think the more experiences you can get under your belt, the better. Reach out to people, don't be afraid. Most doctors are generally nice and they want to help you, learn about the profession in order that you can make a decision if it's something you want to pursue. I do think it's important to know your passion, and I think this kind of comes from experience with shadowing or volunteering. In my case in particular, I had a close family member who got cancer and passed away when I was quite young. And so that sparked my interest in disease and pathology and why, these things happen and how I can help patients. And so that was really my driving passion that helped motivate me to get through all of these steps. So I think it's helpful, not everybody's going to have the same story, but I do think it's helpful to gain these experiences so that you can find your passion. Be realistic with time commitments. Medicine is a long journey. You're going to have to make some sacrifices along the way in terms of family and friends. And, just realizing that early on can only help you just be more intentional with what you are seeking to do with this career. I definitely think it's important to accept failure as a part of success. A lot of times, I remember when I was applying to medical school, I saw doctors as these like non-human superheroes. And, now that I've gone through the process, I know that it's not all success and we're not, perfect human beings and robots that only achieve. In order to achieve, you have to fail sometimes. And that is just a natural part of doing anything in life that's hard. So keep that in mind and don't get discouraged. Definitely enjoy being a lifelong learner because it is true. You will constantly be getting tested and wanting to learn more. And as careers and specialties change over time, you have to learn more, which is exciting. Definitely find support systems and prioritize your well-being so that you can handle the stresses of medical school and residency training because they are real and they will come knocking at your door, and you want to set yourself up for life in general with support systems and ways to kind of relieve stress so that way, when things such as life happen, you're prepared. And then finally, just enjoy the journey. It really is a rewarding career, and it's fantastic to be in medicine and help people every day. So that's all I have, and I'll give it to you guys for questions. Okay, I see some questions in the chat. I guess I could take some of those questions. Okay, so the first one says, based on your experience when considering patients with metastatic cancers, what is usually the complications causing their passing? Would it be an infection, organ failure? What is the most common complication based on your experience? This is a difficult question to answer. There's really not a correct answer to this because it depends on what type of cancer they had to begin with, where it's located. All of that kind of affects, what will ultimately lead to their passing. And so, oftentimes it can be that the patient's cancer is so extensive that their nutritional status goes downhill, that offsets their electrolytes, which is, not compatible with life. Many different things can happen, but each case is different. So I don't have one specific answer for that question. Another question was, what was the most effective study method that you've used in the past? I tend to be a memorizer, so I like to memorize things kind of intensely and then come back to them and see if I remembered them. And then if I didn't remember it, intensely memorize again and kind of do this repetitive process until it comes as like second nature and I can like basically spit it out back to myself without looking. That works for a lot of medicine. There are, instances in medicine where it's more application. So you have to think on your feet and be kind of flexible in terms of your thinking. But I think for me, at least, that's how I study. Another question, what do you do if you do not know something or how to treat a patient? So this is a great question. If I don't know how to do something or I don't know how to treat a patient, I ask and I look up the patient's case in the literature if I can find any data, any trials, or any retrospective series where other doctors have dealt with these types of cases, so I can see what's been done in the past and what works. And then I oftentimes consult other colleagues. And if, I have colleagues that are certainly more experienced than me or older than me that, may have dealt with a similar situation. Same position, and we kind of help each other at times discuss difficult cases. Sometimes it just helps like verbalizing things, but I definitely start with the literature and the data out there and see what's been done in the past.
Okay, I think those are all the questions in the chat. If anybody else has any questions, last minute questions, please put them in the chat. But again, I would just like to thank you so much for coming today, and your talk was so informative. I learned so much I didn't know anything about oncology or radiology before, so I learned a lot. Thank you so much.
Of course, it was my pleasure. If you guys have questions, feel free to reach out to me. I'm always happy to answer more questions. And, it was a pleasure. I hope you guys learned something.
Thank you.
Very